I have allowed participants to join, so you can start. Ma'am, the attendees have started to join, so we can start.
Okay. Let them join.
Arun Chandra, start introducing everybody. We'll start the meeting.
Okay, sir. Thank you. Hello, everyone. Good evening, and a warm welcome to the 42nd episode of The Secret of Neurology. Today, we embark on a fascinating journey into the intricacies of the human brain and the special cases presentation from the esteemed neurology team of NIMHANS, Bangalore. It's my distinct privilege to introduce the driving force behind this episode, our esteemed course director. So, that is Dr. Sudhir Shah sir and Dr. Narasimhan sir, Lakshmi Narasimhan sir. Both are the well-known neurologists of India and well-known personality. So, just to give some small introduction of Dr. Sudhir Shah sir. Dr. Sudhir Shah sir is the professor and head of the department of NHL, MMC and SVP IMSR Ahmedabad, and he is a director of neurosciences, Sterling Hospital, Ahmedabad. Dr. Sudhir Shah sir is a consultant neurologist to the Honorable Governor of Gujarat and past executive committee member at the Indian Academy of Neurology and advisor to the World Yoga Foundation. Sir is having the interest in stroke, neurodegenerative disease, and epilepsy. Further to this, it's an honor to introduce Dr. Lakshmi Narasimhan sir, who is a director and professor of Sri Ramchandra Institute of Higher Science Education and Research, Chennai. Sir has achieved a lot of awards and affiliations. First of all, Palliative Advisors from AN 2007, A.B. Baker's Award for Global Best Teachers of the American Academy of Neurology, Best Paper Award of the American Academy of Neurology and American Indian Neurologist Association 2009. Further to this, Sir has received the Global Elsevier Atlas Award winner August 2015, and Sir is having the executive committee member of World Federation of Neurology. And further to this, Sir has contributed the 3-term executive member in the Indian Academy of Neurology, and he is the CME convener, Indian Academy of Neurology. Further to this, Sir has successfully organized 7 consecutive clinical neurosciences program for all India DM students, graduates, by the name of SHINE, right from 2010 to 2017. So what to say more about Sir, and not to take much of the time, I'll request Sir to introduce the team, today's team of the NIMHANS. Over to you, Sir.
Good evening, everybody. Wish you all a happy 2024. We start the new year 2024 with an academic bang from Professor Netravati and the team. I'm very happy to introduce Dr. Jayant, the postdoctoral fellow in CNS demyelinating disorders in NIMHANS in Bengaluru. He has done his MBBS from the Devangre SS Institute of Medical Sciences and MD General Medicine from BM Patil at Vijayapura and DM Neurology from NIMHANS, Bengaluru. And we know that Professor Netravati is one of the doyens of multiple sclerosis and all the demyelinating diseases and runs the NMO clinic at NMO and MS clinic at NIMHANS. And he is working with him as a fellowship. Welcome you, sir. Dr. Vikram B. Hola, Associate Professor, Department of Neurology, National NIMHANS, Bengaluru, who has qualified from MBBS from Bellary, MD General Medicine from Delhi, DM Neurology from KGMC Lucknow, and PDF in Movement Disorders in NIMHANS, Bengaluru. Area of interest is movement disorders, neurogenetics, more than 90 publications, national international journals, co-chair of web-based learning in MDS subcommittee, member MDS web editor and board, and member of infection-related movement disorders in MDS group study group. Welcome you for this Neurology Secrets 42nd edition, sir. Next, Professor Netravati, well known across the country for her stupendous work in multiple sclerosis. She runs the MS NMO MOG clinic and autoimmune encephalitis and neuroimmunology are areas of interest. Neuroinfections, TB, meningitis, neurocystic encephalitis, and HIV-related neurological disorders. MS and NMO clinic at NIMHANS every fourth Saturday of every month. Started the first postdoctoral fellowship in CNS demyelination in India. Publications in 122 publications and book chapters. A very high H index person. And most important, she's so modest and humble. As a human, you will really want to respect her. Public professional activities, task force members of WHO, part of the National MS Task Force, co-principal investigator for National MS Registry from NIMHANS, founding member of MDSI, part of the NIHR Global Research Group by Brain Infections Liverpool, part of the Global COVID-19 Neuro Research Coalition, state member of the Adverse Effects of COVID later. And I request Professor Netravati, I thank her for accepting our invitation to join the 42nd meeting of the Neurological Secrets. Over to Professor Netravati to take over the proceedings. Thank you.
Thank you. At the outset, thanks Dr. Lakshmi Narasimhan sir and Sudisha for giving NIMHANS this opportunity. What happens is most of the time, this is mainly what we have intended today as a teaching session. It is easy most of the time as a CNS demyelination, most of them end up trying to either differentiate between multiple sclerosis and NMO, or even if they're not able to differentiate, the approach would be to just give steroids and then immunomodulation. So what we are trying to show here is about a patient who was actually diagnosed as a demyelinating disorder and how should we approach this. So that is what we are trying to plan in this next few minutes. And for this, we have Dr. Vikram Hola, as already sir has introduced, and Dr. Jayant. So Jayant, the floor is for you. Can we start?
Yeah, good evening, ma'am. Good evening, respected teachers and everyone. I'll just share the screen. Yeah, can I start?
Yes, you can start, please.
Yes, Jayant, start.
Yes. So I'll be presenting about a case of a 22-year-old gentleman who is from Chitradurga, Karnataka, formally educated up to 10th standard, with chief complaints of diminution of vision in both eyes since 2010, walking difficulty in 2019, and 2 episodes of headache followed by diminution of vision in January 2023 and March 2023. So the patient was apparently normal till 10 years of age, and when he had a progressive blurring of vision in both eyes, initially for faraway objects that gradually progressed to involve the near vision as well. So he was evaluated at local place and diagnosed with diabetes. So thought of it as a complication of diabetes. and was started on treatment for the diabetes. He was able to see objects near to the face. Subsequently, in 2013, that is at around 13 years of age, he had an episode of tonic-clonic movements involving the right upper limb with posturing of fingers with intact awareness, and admitted, and he was evaluated, diagnosed to have had a seizure, and started on anti-seizure medications. While the patient was on anti-seizure medications, he had recurrence of seizures in 2016 with similar semiology. Despite being on the anti-seizure medication, was evaluated and they were titrated. In 2019, he developed acute onset weakness of both the lower limbs in the form of complete inability to walk, which was associated with double incontinence. He was evaluated at an outside hospital and diagnosed to have NMOSD. And he was treated with parenteral steroids followed by oral steroids, over which patient reported complete improvement in symptoms. And oral steroids were thereafter maintained for around 2 to 3 years afterward, and azathioprine 50 mg per day was started. In January 2023, he had an episode of holocranial headache, which was moderate to severe in intensity, which reached its peak intensities in an hour and was associated with complete loss of vision. He was evaluated and diagnosed to have intracerebral bleed with, however, he had normal blood pressure. So headache resolved around within 4 to 5 days. However, vision gradually improved and returned to 50% of the baseline around February 2023. However, in March, he had a similar intensity headache with complete loss of vision this time. Headache resolved, but the vision loss persisted. At this point of time, as there was no improvement in symptoms, he came to NIMHANS. Coming to the treatment history, at 2010, when he was diagnosed to have diabetes, he was started on insulin. And in 2013 and 2016, anti-seizure medications were started and titrated respectively. In 2019, he was started with IV steroids followed by oral prednisolone. The dose details are not available, which was tapered by around 2022. And from 2022, he switched over to azathioprine 50 mg per day until the day he presented to in NIMHANS. Birth and developmental history. He was second born of second-degree consanguineous parentage, full-term normal delivery, cried immediately after birth, smooth perinatal transit, and age-appropriate milestones were achieved. So coming to the pedigree chart of the here we can see he is born to the second degree, is second born, and the elder sibling does not have any comorbidities, and his mother, diabetes runs in his mother's family. However, on inquiry, all of them have had diabetes after the age of 30 years. So summarizing, so this patient presented with progressive bilateral painless symmetrical visual impairment in 2009. That point of time, diabetes mellitus diagnosis was made and was started on insulin. Subsequently, he had a seizure, which was right focal motor seizure with retained awareness in 2012. And he was diagnosed to have epilepsy and started on anti-seizure medication. And in later, he had complete paraparesis with sensory motor autonomic involvement, which was resolved. This was in 2019. He was diagnosed to have NMOSD and he was started on steroids with azathioprine. And subsequently in 2023, he had acute onset headache followed by visual loss with limited improvement. He was diagnosed to have intracerebral bleed and symptomatic management was there. As there was no improvement in the vision, he ended up in NIMHANS. Now I'd like request Vikram sir to analyze the symptoms.
Yeah, thank you, Jayant. At the outset, I would like to extend my gratitude for giving me this opportunity to discuss this interesting case. As he has already summarized, so we have a patient who is with an early sort of late first decade or early second decade onset neurological symptoms, which have two progression in the form of one that is relentlessly progressive and they're worsening in between with a newer episodes as well. Coming to the first symptom, that is progressive bilateral painless symmetrical visual impairment. So this was, slowly distant thereafter in the near symptoms are also being affected. So when they have a bilateral painless symmetrical visual loss, either it can be sometimes because of the anterior chamber like cataract or corneal abnormality, mainly cataract, but very odd to have in this age, or it can be because of retinal abnormality like in the case of optic neuropathy or optic atrophy, or sometimes progressive leukoencephalopathy involving the occipital cortex can also have this progressive visual impairment. So these are the three localizations. At that point of time, he was also diagnosed to have diabetes mellitus, probably type 1 because he was started on insulin. However, and it was attributed to diabetes. But the point to be noted is usually type 1, I mean, the microvascular changes happens after a prolonged duration of uncontrolled sugar. Whereas in case of type 1 diabetes, usually the hyperglycemia happens at the onset itself. So we usually get microvascular changes after 5 to 10 years. So it is very odd to get a microvascular change at the diagnosis of type 1 diabetes mellitus, which we often see in type 2 actually. So the visual impairment is very unlikely to be to be attributed to diabetes itself, because this cannot happen in a type 1 diabetes mellitus, very odd. So coming to the next, we have a multiple episode of seizure, which is a right focal motor seizure with intact awareness localizing to the left motor cortex. So when there is a focal seizures, we should always think of a focal lesion. However, one has to note in case of hyperglycemia and also sometimes in hepatic encephalopathy, the patients can have focal onset seizures also. So focal onset seizures can happen in metabolic derangements in such scenarios like hyperglycemia and hypoglycemia also, and in case of hepatic encephalopathy. So this may be very likely to be because it was spanning long duration. So very likely to be some focal lesion in the left motor cortex, but can also happen because of uncontrolled hyperglycemia. And then the complete paraparesis with sensory, motor, and autonomic involvement in the form of double incontinence, which resolved almost completely to the extent that he was able to walk independently with steroid, initially IV, followed by oral, and then azathioprine. So we would like to consider any inflammatory cause in this because of the steroid responsiveness and remitting nature of the illness. And the localization will be because of the paraparesis and autonomic involvement. It will be called cervicodorsal, upper dorsal, or sometimes lower cervical also. There can be a drop down level. And coming to the acute headache followed by visual loss, it is a painful visual loss, and 2 episodes have happened. Because of the headache, it was headache rather than a periorbital pain. So more likely to be in some intracranial abnormality rather than the optic nerve abnormality in this particular case. And the headache was quite acute and quite severe. So possibility of cortical involvement or the cerebral parenchymal involvement is higher rather than having optic neuritis because of the holocranial nature of headache, which can happen, but usually it is periorbital in optic neuritis. So, and at that point of time, the imaging also showed intracellular bleed, and he was given symptomatic treatment. So these are the localization we can sort of consider based on the symptoms that we have at the time of presentation.
Thanks, Jayant and Vikram. So you can see here very nicely Vikram has analyzed most of the symptoms, the history which the patient presented. So this is a long-standing history with almost childhood onset of illness and on a background of diabetes, where the patient had a visual dysfunction which again came back, especially with the intracerebral bleed, with an episode of myelopathy, and then seizures, which was there for few years in between for 3. So you can see here, it is not the usual temporal way, the way demyelinating disorder goes through. So just telling based on this itself. So what happens is, if you see at 2019, he was diagnosed as NMO spectrum disorder and started on immunomodulation. So most of the time, even whenever we discuss about any disorder, one of the things when we are not able to differentiate whether it is immune mediated or non-immune mediated, especially in an elderly person who comes with an acute visual dysfunction, arterial or the vascular causes, ischemic causes will be first on the list. But sometimes they can even have a transient improvement even without medication, or even whatever you give, whether you give aspirin or you give immunomodulation, they will definitely show improvement. But sometimes what we take is this immune responsiveness, we take it as for in the diagnosis of a demyelinating disorder. So that is what was happened even in this case. I'm not negating that, but we should remember this, that always the steroid responsiveness or immunomodulation responsiveness may need not be just associated with demyelinating disorder. Why? That we will bring it out in the eventual slides, but I just want to stress on this. Because this is a patient who is having a onset of illness, though we do have pediatric demyelinating disorders, there is a chronic progressive illness, especially in the form of visual impairment and seizures on the background. And then the patient has developed 2 different axis involvement. One is the spinal cord in the form of myelopathy, and then there is an intracerebral bleed. suggesting that this is completely a different etiology. So at this point, I would like to just keep it at this level, and we will see what was the examination. Jayant, you can go with the examination, then again we can have the discussion. Jayant, you're muted.
Thank you, ma'am, and thank you, sir. So going to the examination. So the vitals were stable, and he had a short stature with dependence contracture of fingers of both the hands. And on general examination, there was no hepatosplenomegaly. Coming to CNS examination, speech was normal. Optic nerve, visual acuity, the bilateral perception of light was negative. Fundus showed bilateral optic atrophy. Pupils were 5 mm dilated and sluggishly reactive to light. And extraocular movements were full, and there was bilateral gaze above nystagmus. Rest of the cranial nerves were normal. There was spasticity of both the lower limbs, and power was normal, and reflexes were 3+ in the upper limb, and ankle jerk was 4+. Plantar was bilateral equivocal response. Sensory system was intact. There were no cerebellar signs, and he had a spastic gait. So combining both history and examination, I'd like to summarize. This 22-year-old male patient presented to us with a history of chronic progressive optic neuropathy, type 1 diabetes mellitus, focal motor seizures, residual myelopathy features in the form of lower limb pyramidal signs, and 2 episodes of acute onset headache followed by visual dysfunction. So I'd like to invite Vikram sir to discuss the differentials after history and examination.
Thank you, Jayant. So in this case, as can happen in many other cases, the examination, may not yield too much. Apart from clarifying certain features, history may still be very important. That is why we should always spend some time with history, because examination findings will be, there might be resolution, or everything cannot be seen in examination. So apart from the history, examination yielded us like bilateral optic atrophy, suggesting that visual impairment was because of the initial visual impairment is most likely because of the optic neuropathy. And 3-month duration is very short for having atrophy. So the initial abnormality may be because of the optic neuropathy itself. And apart from that, the patient had residual signs of paraparesis, spasticity in the lower limb with Briss reflexes. So that may be the residual evidence of myelopathy that he had in 2019. Combining everything, the patient had diabetes, the patient had optic atrophy, bilateral slowly progressive in the very early age of onset, seizures, and also headache. All these features, one of the common DDs that we keep when there is multisystemic involvement, with especially diabetes and visual impairment, optic atrophy in a child in early onset, is mitochondrial. However, although myelopathy can happen in mitochondria, it is not the usual feature that we see in mitochondrial cytopathies. And it also, there was a response, steroid responsiveness was there. Although, as ma'am told, that responsiveness doesn't always suggest it is acquired or it is inflammatory. But that is also a bit odd point, but it can happen in mitochondria. The other possibility, because of the intracerebral bleed, the patient had acute onset headache, and myelopathy also, as ma'am told, sometimes the improvement may not be because of the steroid that we gave, but maybe the usual course of illness, that the spontaneous, or the usual recovery that can happen. So the seizures also, acute onset headache with visual impairment. So these features suggest a possibility of vasculopathy, early onset pediatric vasculopathy, and the type, but the vasculopathy alone cannot include why the patient had type 1 diabetes and what was the reason for progressive visual impairment. So vasculopathies can have retinal vascular abnormality. Again, will have a sort of stepwise or acute worsening, sort of bilateral symmetrical visual impairment is a bit odd to explain just based on the vasculopathies. So these are the 2 DDs that we kept at the end of examination, and these were the 2 major DDs that we had considered. You have anything to add?
I think you have discussed most of the things, Vikram. We can have the discussion later. Jayant, you can go ahead. Dr. Lakshmi Narasimhan sir, you want to add anything at this point of time before we go ahead with the investigations? I think we'll go ahead with the investigations, Jayant.
Okay, ma'am. Coming to the investigations, so the hematology investigations, the complete blood count, the liver function test, renal function test, and serum electrolytes were normal. HbA1c was 11.8%, B12 levels was 840, folate level was 4.7, and homocysteine was 10.9. Ammonia and lactate were in the normal range. ANA profile was negative. Anti-aquaporin 4 and anti-MOG IgG antibodies were negative. APLA was negative, and the viral markers, including HIV, HBsAg, HCV, were negative. We did a CSF analysis. The CSF was clear and it had nil cells, and protein was around 33, glucose was 212, lactate was 21, and cytosine did not show any cells. India Inc. gram stain was negative, culture report was negative, scrub typhus and brucella PCR were also negative. We did a formal opthal evaluation, which with the visual acuity of no perception of light, pupils were mid-dilated, non-reactive, fundus showed advanced optic atrophy, and the rest of the retina was normal. We went ahead with the EP studies, and VEP, bilaterally it was absent. And coming to BERA was normal in both. And SSEP, upper limb SSEP was normal and the lower limb SSEP was absent. Coming to images, so we have a few images of the previous episodes. So this image is of March 2019. This was taken during the episode of myelitis. So we can see, sorry for the poor quality of the images. So we can see a non-enhancing hyperintensity at the level of D1, and it is almost up to D4. And I'm sorry, it's an enhancing lesion at the same level in the contrast, and the brain screening was normal. And subsequently, this is the MRI of January 2023, where the patient had this acute onset headache, which was followed by right visual loss. Here we can see acute hematoma in the right temporoparietal region. The next MRI of March 23, where the patient had the similar episode of headache followed by visual loss. Here the patient had a new hematoma in the left occipital lobe. So when the patient came to NIMHANS with these MRIs, these were discussed, and the other films have not been put because of the poor quality, which showed microbleeds and macrobleeds at various stages, and there are few asymptomatic bleeds also. So at this point of time, we thought of three differentials. One was vasculitis, and the other was infection in view of the enhancement, which I'll be showing next. And because of asymptomatic bleeds, metastasis was also thought of. This was the MRI which was done at NIMHANS. So this MRI shows you heterogeneously hyperintense content with peripheral rim. This is the T2 axial and this is T1 axial, which shows further central diffusion restriction. And on contrast images, it shows a nodular sulcal enhancement in the left temporoparietal occipital lobe and right frontal lobe, which further correlates with this T1 images which I had shown. And these are the further images, a SW image which shows a focal areas of folial bleeding in the left cerebellar hemisphere and multiple areas of microhemorrhages, pointed the arrows in bilateral frontoparietal lobes, and focal areas of sulcal siderosis in the left frontal lobe, and SW and phase images showing hypointense signals in the magnitude images, and which are suggestive of lobar hemorrhages in right temporal and then right basifrontal and left occipital lobe. This was the spine, which showed a longitudinally extensive transverse myelitis, which we can see here, which shows few foci of ring enhancement in the contrast images. So this was one of the thought process of thinking behind the infective etiology. And these images further show the axial cuts, show the hyperintense changes with contrast enhancement. So in order to rule out vasculitis, we went ahead with the DSA, and the DSA was normal in him. So after the investigations, I'd invite Vikram sir to summarize and discuss regarding the differentials.
Thank you, Jayant. So at the end of investigation, so we have a patient who is having sort of relapsing remitting neurological illness in the form of one myelopathy with type 1 diabetes, progressive optic atrophy, and also focal seizures. and along with MRI brain that suggests multiple microbleeds, large bleeds, and also there is some enhancement, punctate and nodular enhancement in the spinal cord, which can also be happen sometimes in vasculitis. In the view of no systemic, the blood investigations being negative for ANA profile and other systemic vasculitis feature. So MRI features of small vessel CNS vasculitis because DSA was normal, and based on this, the acquired cause, one of the acquired causes were thought of, like primary CNS vasculitis involves relaxing emitting steroid responsive nature of the myelopathy. Although myelopathy is a bit uncommon, but it has been reported and with the varying frequency of 5 to 30% based on the MRI study. But again, the type 1 diabetes and the progressive optic atrophy was sort of always sticking out like a short term. I mean, just based on the CNS vascularities, it was a bit difficult to explain why these things would be. Apart from that, because of the early age of onset and the very prolonged duration, the patient had type 1 diabetes, consanguinity, short stature. So all these things made us think, is there a possibility of underlying genetic cause, such as genetic vasculopathies, which Jayant will be discussing in the further slides. And mitochondrial cytopathy was always in the picture with the optic atrophy, diabetes mellitus, serious stroke. But usually stroke-like events happens with sort of ischemia rather than intracranial hemorrhage. Intracranial hemorrhage is a bit odd for a mitochondrial cytopathy. The patients have multiple microbleeds and also large bleeds also. So that was the, again, very odd one for mitochondrial. So acquired cause followed by genetic cause was what we thought of. At this point of time, in view of possibility of genetic cause and other reports being inconclusive with etiology, so we went ahead with the horizon sequencing and mitochondrial genome sequencing. And meanwhile, while waiting for the report, we went ahead with the treatment, which Jens will be discussing for this slide. Anything else you want to add?
I request the attendees to put up the differential diagnosis so that we can have a discussion before we show as to how to approach this patient. Okay, just to add few things. So most of the things Vikram Holla has told about how to approach. One thing is whenever we, in this case, the initial suspicion was of the CNS vasculitis, but here DSA was negative. But we should also remember, we do have a DSA negative CNS vasculitis, and that is seen primarily in primary CNS vasculitis when your small vessels, that is the very distal most vessels, when they are involved. That time your DSA can be negative because those distal small vessels will not be picked up by your angiogram. So even that time, the other sequences or MRI and your clinical is again a clue to differentiate whether it is a CNS vasculitis or a non-CNS vasculitis. So we should be aware of this. Next, coming to the responsiveness to steroids. There is an entity of mitochondrial disorders where most of them can show responsiveness to steroids, especially when there is a white matter involvement, and also in cases of Leigh's disease. So these are few conditions. So what happens is, you may have a multi-axial involvement, but when you have a multi-axial involvement, if you see it is a Leigh's disorder, or if you see that there is sudden acute worsening, there have been shown multiple series other and case reports where they have shown responsiveness to steroids. So we should be remembering this. And the other thing is, though odd point of myelopathy was discussed, there is an entity of ARS and DAD. I think one of the attendees have put up in the Q&A about where they can have a mitochondrial disorder with myelopathy involvement, and those people do respond to immunomodulation, that is steroids, plasmapheresis, and sometimes some people have even tried rituximab in those conditions. So we should be aware of these. But apart from that, if you take into consideration of genetic vasculopathies, which Dr. Jayant will discuss, I think Jayant, if you can discuss the genetic vasculopathies.
Yeah.
1 second.
Sure.
1 second, 1 second. One person has asked about, is it useful to do a SSCP if already radiologically myelopathy is there? See, this SSCP was done at this point of time when the patient came to us to NIMHANS, when the myelopathy had already resolved. So we are already having a patient where the myelopathy was in 2019, and after that In 22, the patient has developed intracellular bleed, and 22, the patient has come to us. That is nearly around 2 to 3 years after the onset of myelopathy. That was the reason for doing the SSCP, basically to look at the multi-axial involvement. It was as part of the diagnostic and evaluation workup, nothing more it is going to give. Then the other question is about how a vessel wall MRI will be useful in this case. I think basically because, as Jayant already told about both the microbleeds and the macrobleeds, that was the reason for suggestive of a CNS vasculitis. As you can see that many of them, this patient had an intracerebral bleed. And this intracerebral bleed especially can be marker for a CNS vasculitis, as well as the way the progression of the history was there. So that was the reason for doing the angio in this patient.
A point to add, Dr. Netravati.
Yeah.
I just wanted the SSCP for the sake of postgraduates. SSCP evaluates the posterior column. The laser evoked potentials evaluates the spinothalamic, and the central motor conduction time evaluates the corticospinal tract. So the electrophysiological equivalents of pyramidal involvement is central motor conduction time. Electrophysiological equivalent of involvement of posterior column is SSCP, and involvement of laser evoked potential is electrophysiological equivalent of spinothalamic. This is for the sake of the postgrad. I just wanted to add that. Thank you.
Yeah, thank you.
Yeah, ma'am, before going to genetic vasculopathy, shall I tell her about the treatment?
Yes.
Yes. So, as Netra ma'am and Vikram sir already discussed, so two of our main differentials was, one was vasculitis, the other was mitochondrial. At that point of time, when the patient was with us, we did not have a definite clue as to what. So we went ahead and treated the patient with both mitochondrial cocktail, as well as the patient had before previously responded to steroids well. We treated him with IV methylprednisolone 1 gram for 5 days, followed by oral steroids and 4 cycles of plasmapheresis. And rituximab was given on day 1 gram on day 1 and day 14, and the anti-seizure medications were continued. So I'd like to discuss about the response. I'd like to tell later. Now I'll discuss about the various genetic vasculopathies, which we can think of now. So I'd like to briefly tell about all of them at a fast pace. The first one is Gurity syndrome, where TREX1 mutation, SMAHD1 mutation is seen, where we can see punctate basal ganglia and white matter calcifications with leukoencephalopathy with white matter cysts. And vascular imaging, we usually see an intracranial arterial stenosis and occlusion of the distal internal carotid arteries. Other clinical manifestations, they'll be having microcephaly and cutaneous chilblains. So coming to CADASIL is because of Notch3, as we all know. CARASIL, CTSA, and CARASIL HDRA1. So in CADASIL, we'll have this diffuse white matter hyperintensities in the anterior temporal lobe with lacunar infarcts. There are no characteristic features in the vascular imaging findings, and they'll also have migraine, and family history is extremely important in them. So CARASIL, they will have this diffuse white matter T2 hyperintensities and early external capsule involvement, and arc sign is seen in the pons. Along with that, other clinical manifestations include alopecia, spinal arthropathy. Then coming to Hun syndrome, so TREX1 mutation, usually age at first stroke will be 30 to 45 years. They'll have this frontoparietal enhancing mass-like T2 hyperintense lesions. Along with that, they'll also have retinal microangiopathy, Raynaud's phenomena, nephropathy. Fabry's disease, where there'll be infarcts and white matter lesions with a posterior predominance and pulvinar T1 hyperintensities. And vascular imaging, there'll be intracranial arterial stenosis or ectasia. They'll also have cardiac failure and renal failure along with it. So these are predominantly large vessel disorders like ACT2 vasculopathy, Alagille syndrome, Grang syndrome, Moya-Moya disease, neurofibromatosis type 1, sickle cell disease. So, and this predominantly hemorrhagic disorders, that is COL4A related disorder, where genes involved are COL4A1 and COL4A2. And typical age at first stroke will be around 30 to 40 years of age, and they'll have this intracranial hemorrhages, lacunar infarcts, and microhemorrhages. There'll be porencephaly in neonates, and intracranial aneurysms can be seen in vascular findings. Along with this, they have Hannack syndrome, they'll have nephropathy, aneurysm, and muscle cramps. Then the other one is HCHWAD, A beta PP gene is the one which is involved, and they'll present a little late at around 40 to 60 years of age. They'll have recurrent lobar and subarachnoid hemorrhages, microhemorrhages with a lobar distribution. Vascular remain, there'll be no particular characteristic features. So these are the various genetic vasculopathies which are rarely encountered, but these are the ones which we encounter at a common distance. So I'd like to invite Vikram sir to discuss about the next genetic reports and other things which we went out about.
Anyone from the attendees want to add any differential diagnosis or this point of time? Or ma'am, any? In the interest of time, we can go ahead, Jad, you can go to the next slide.
Okay, sir.
Yeah, the whole exome sequencing and mitochondrial genome sequencing report had come a likely pathogenic homozygous variant in WFS1 gene. That is a gene that is responsible for Wolfram syndrome type 1. So this is an autosomal recessive disorder, and this particular variant that was identified was extremely rare in normal population database, which classifies the PVM1, that is moderate pathogenicity 1 criteria. And this variant is situated in a mutational hotspot. There are 10 pathogenic variants in this particular exome. So that makes that exome very important for that particular protein. So that this classifies the moderate pathogenicity type, second moderate pathogenicity criteria. And it also is predicted to be deleterious by in silico methods. And the variant has been previously reported to be likely pathogenic in the ClinVar, that is the publicly available database for various variants. So put together, 2 moderate pathogenicity and 2 supporting pathogenicity will result in a prediction of likely pathogenic variant. So this was, the final genetic diagnosis based on the genetic report was Wolfram syndrome, which is also known as Didmot syndrome. Someone had put in the chat this one Q&A box. So although the patient that has diabetes insipidus, diabetes mellitus, optic atrophy, and along with the deafness, our patient had 2 of these 4 features. And there was one additional feature, which was like the patient had a CNS vasculitis like picture both clinically and as well as radiologically. So this was, as far as this one, so it's not a common, it is not a feature that has been described in Wolfram syndrome. So this was odd for this particular diagnosis. Jayant will sort of discuss these cases. So are we dealing with a single disease? Are we dealing with 2 different diseases? So that was our query. And ma'am, you want to add anything?
No, I think we can go ahead and we can discuss.
Then you can go and discuss the case. What was, pertaining to our case and also what is the syndrome.
Yes, sir. So I'd like to quickly brush up on Wolfram syndrome. So it's an autosomal recessive genetic disorder which is characterized by juvenile onset diabetes mellitus, insipidus, optic nerve atrophy, hearing loss, and neurodegeneration. It was first reported in 1938 by Wolfram and Wagner, who found 4 of 8 siblings with juvenile diabetes mellitus and optic nerve atrophy. So 2 main subtypes are known of 2 different mutations. That is type 1 caused by the mutation of the Wolframin gene, and the type 2 which is due to the mutation in CASD2 gene. So it is also called Didmot, as Vikram sir told. It's frequently used to describe the classical clinical features. Along with that, Wolfram syndrome also encompasses a spectrum of abnormalities beyond the cardinal symptoms, including neurological, psychiatric, urological, endocrine, and rheumatologic manifestations. So Didmot stands for diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So the neurological manifestations, they usually have slowly progressive and they occur later in about 60% of the Wolfram syndrome patients. The MRI demonstrates usually general brain atrophy, which is prominent in cerebellum, medulla, and pons. Common symptoms include ataxia, central apnea, dementia, loss of gag reflex, loss of olfaction, lower cranial nerves will be involved, headache, myoclonus, epilepsy, nystagmus, gastroparesis, constipation, and orthostatic hypotension. So they tend to have bleeding tendency, which the pathogenesis of this is still unclear. And this is a peculiar feature of WS2, since no cases of abnormal bleeding have ever been reported in WS1. So these are the various clinical differences in between the type 1 and type 2. Current management of Wolfram syndrome is supportive due to lack of disease-modifying treatments that can halt the progressive neurodegeneration in this disorder. Strategies which are being developed include chemical chaperones to optimize the structure of the mutant WS1 protein, and then endoplasmic reticulum calcium stabilizers that target the calcium transporters molecules which regulate this endoplasmic reticular stress-related mediated cellular apoptosis and activate cell survival mechanisms and modulators of mitochondrial function. So coming particular to this case, the neurological complications are common in Wolfram syndrome type 1, as I told, affecting around 60% of the patients with onset in young age. And the classical presentations include with diabetes and vision loss in early adolescence, which was there in our patient. We also had seizures, which have been documented in patients with Wolfram syndrome. Our case stands out due to the distinctive presentation marked by paroxysmal events such as steroid responsive myelitis and stroke-like episodes. And why was there an intracranial bleeding? The recurrent intracranial bleeding in our patient also stands out as a unique phenomena yet to be reported in this rare entity. Though Wolfram syndrome type 2 patients have been shown to have bleeding tendencies, particularly GI bleed, but ICH has not been reported in the literature. Our patient had WS1 genotype and phenotype in which even bleeding tendencies have not been reported. So this makes it a rare occurrence. And the cause for bleeding is still not clear. Several hypotheses can be made, like microvascular complications of diabetes, a continuum of WS2 pathology, or vascular abnormalities. So this is one paper where they did optical coherent tomography in neurodegenerative optic neuropathies, where they found out that OCTA studies in Wolfram syndrome revealed unique vascular changes such as temporal optic nerve head capillary plexus attenuation, peripapillary microvascular alterations, and the presence of telangiectatic blood vessels with vascular tortuosity. So whether such vascular abnormalities exist in the other intracranial vessels also, this needs to be explored. So I'd like to invite Netra ma'am for the further discussion. It's point of time.
Thanks, Jayant. So what I would want to tell about is the approach. I think some of them have asked about the genetic clarifications, which Vikram Holla will clarify. I just want to talk about few things. So in this case, what we have to learn is there was a progressive visual impairment which was there. So always remember, whenever you have a visual dysfunction, especially if it is unilateral associated with eye pain and acute to subacute, then thinking of a immune mediated cause would be more apt. But when you have a progressive visual dysfunction, when it is bilateral, going on for many years, then you will have to think of other non-immune mediated causes. Most of the time, it would be a genetic or a metabolic causes, and sometimes even nutritional causes also do causes progressive visual impairment. So that is one thing. Second thing is about the dysmorphism and short stature which was there, and early onset diabetes. All of this usually point towards a metabolic disorder. Usually we think of a mitochondrial etiology with this background, especially as Jayant showed about the pedigree chart about the multiple people affected with diabetes in the family, and he himself having all these features. So that is also one thing which we need to know. Next is the patient had a Dupuytren's contracture, which can happen with a long-standing diabetes, but usually described in type 2 diabetes mellitus, not in type 1 diabetes, as is this patient. So here we had a patient who had lot of dysmorphism, short stature, Dupuytren's contracture, progressive visual dysfunction leading to optic atrophy, intracerebral bleed. So just like how you have in neuromuscular disorders where you have the COL4, which is there, as Jayant already showed, most of the genetic vasculopathies cause two different type of involvement. One is they have ischemic involvement or just a white matter involvement. So what happens when it is a ischemic involvement? They develop either an acute onset of stroke or acute onset of neurological disturbance on one side. Whereas when it is a genetic cause of a white matter involvement, then they have the diffuse white matter like a leukoencephalopathy which happens. That time they have a progressive cognitive impairment, and sometimes they also have few cases they can have even extrapyramidal, but it is usually hypokinetic type, and sometimes even also discussed is the onset of bulbar dysfunction. So these are the few clinical spectrum which happens with genetic vasculopathies. So the only genetic vasculopathies which are associated with intracerebral bleed is call for mutation, where it also correlates with the Dupuytren's contracture and the dysmorphism which was there. And that is what we had thought initially when the patient had come. So this is just for the discussion, but we should always remember. So the other thing is about the steroid responsiveness or the immunomodulation responsiveness, which I've already talked about. So coming to all this, so though we have a genetic diagnosis in this case, when we do not have a genetic diagnosis, so these are the clinical clues we need to take over and try to differentiate between immune mediated and a non-immune mediated disorders. Apart from this, clubbing both the metabolic as well as the vasculitis, the inflammatory disorders, recently we have many disorders which are coming as interferonopathies. This is one thing where you can have something like inflammatory disorders or granulomatous disorders, but they will be usually again because of some genetic etiology. So these are newer ones which are being more widely described, and we should be aware of these things. So Vikram, would you want to discuss especially about the genetic, which two people have asked in the Q&A?
Yeah, thank you, ma'am. So as ma'am already briefed, I mean, one thing about the genetic testing is with the increased utilization of genetic testing. So we are seeing the widening of the spectrum with rare associations. Are they really because of the particular disease, or is it a coincidental association? Is one of the questions that we should always ask sometimes, especially in this case. Although there are studies that say there can be vascular abnormality in Wolfram syndrome, but you can argue also that it may be coincidence, but it is very difficult question to answer. And sometimes because of the sensitivity of the genetic testing, we get to see incomplete sort of spectrum, in the sense as in this case, the patient did not have a diabetes insipidus and did not have deafness. Even on Bayer also it was normal. So the complete spectrum we may not be able to see clinically. So it will be just a partial spectrum. So coming to the genetic testing, so in this case, whole exome with mitochondria was considered because so nowadays each lab has their own panel sort of. So usually mitochondria in this, because we thought of mitochondrial cytopathy and we wanted, if a particular patient has a very strong particular genetic etiology, like for instance, say a patient comes with the DMD and kid with muscular dystrophy and we think it is DMD, then it is advisable to send one particular single gene testing. So in this case, the vasculopathy, although, I mean, clinically we thought of one particular vasculopathy, but it is non-specific. I mean, it can happen many various other sorts. So, and it is Sanger's was done initially. Once the next generation sequencing has come, it is working out cheaper and more exhaust. It can look at all the genes also. So, whole, I mean, exome sequencing would be beneficial. It will be cost effective also. Your one Sanger can look for only one particular variant in one gene. So it is not like one whole gene will, if it is a very big gene, it is not possible to do Sanger sequencing for the whole gene. It is very time consuming and costly also. Whereas exome sequencing is cheaper. If you see, I mean, if you want to look for 3-4 genes, yeah, then the Sanger sequencing will be costlier than the exome sequencing, which can look for all the genes that are there. So that is why whole exome sequencing or a clinical exome also would be beneficial. If it is negative, Sanger is not going to add anything further. So if it is negative, either we are dealing with, if it is genetic and exome sequencing is negative, either we are dealing with those genetic disorder variants which are there in introns or repeats, or some other mechanism it is causing the genetic disorder which cannot be picked up with exome sequencing, or we are dealing with genetic disorder which are yet to be identified, or we are dealing with non-genetic cause. So these are the possibilities when we get a suspecting genetic, but then we get a negative report. So these are my comments for the questions that were raised in the chat box.
Lakshmi Narasimha sir, you want to add anything? Okay, I thank Dr. Jayant and Dr. Vikram Holla for bringing about this case. So basically what we tried to describe in this case was how do we approach when a patient comes to us Sometimes the patient may come to us, especially after we would be either the third or the fourth or the 10th doctor, but the patient would have been diagnosed as some immune mediated disorder. But still, we should always try to look the patient from the first when the patient has started developing the symptoms, and always the clinical neurology should always hold upper hand. Nowadays, most of the time now, for example, in this case also, though we got a genetic diagnosis in the end, but especially with steroid responsiveness, diagnosing this as an immune mediated disorder and treating for long term with immunomodulation would not have been necessary for this patient, especially with the uncontrolled diabetes which was there. So we do not know whether all that was also one of the reason for having the intracerebral bleed, but because this is one of the rare entity, so it basically the main message is about the clinical neurology has to be there. So we'll always have to approach a patient with what was the clinical scenario which was there and how to go about. Sir Lakshmi Narasimhan sir, are you there? You would want to comment anything?
Yes, yes, yes.
Yes, sir. Yes.
Yes. In fact, sir, wonderful disposition of the lovely genetic vasculopathy. Wolfram. No, I remember. I don't know whether you in our days did this patient had Wolfram patient? Do they have polydactyly?
This patient did not have, sir.
No. Did the normally do they is polydactyly described feature? Is Wolfram's?
Yes, sir.
And I still remember. Huh?
Yes, sir.
In fact, those days when we were students, when I was doing my MD, this Lawrence-Moonbiddle syndrome, Wolfram syndrome, they're all high insulin resistance syndromes. They're all taught to be insulin resistant syndromes, were characterized by polydactyly, retinitis pigmentosa, and vascular. That's what we were taught. And those days we used to have sulfated insulins, which one unit will give 400. Because of the insulin resistance, these high insulin resistance symptoms they used to prescribe sulfated insulins. And I'm talking about the you may not be even born. I'm talking about the 80s, 81, and those times where the only other insulin was sulfated insulin, where 1 unit is equal 1 ml is equal to 400. So every time they used to check whether they use the vial, whether it's a sulfated insulin, because it contains a lot of units, so patient should not go in for. And these all come under insulin resistance syndromes in those. I don't know whether these patients also exhibit Wolfram. Does it exhibit insulin resistance metabolically?
Whatever we have read, sir, there is a diabetes mellitus, diabetes insipidus. The insulin resistance, Jayanth, is it there? Did you
Yes,
read
sir.
on that?
Yes, sir. It is known to have.
Yeah. For a long time back, I still remember Harrison had only a paragraph of high insulin resistance syndromes in the diabetes chapter, where this Wolfram and Lawrence-Moonbiddle were part of along with retinitis pigmentosa. These were all the polydactyly, retinitis pigmentosa, insulin, diabetes mellitus used to be a differential. That's for. And secondly, my extreme thanks to the entire team, wonderfully taken through a clinical discussion. It still says the clinical neurology is still there and still so much challenging. What presented as the entire spectra, myelitis, intracerebral bleed, seizures, what it's a wonderful case. Thank you so much, Professor Netravati. As usual, the presentation for NIMHANS will be one of the top in the crown of the secrets of neurology. I'm sure this will occupy the top layer of the presentations. And I extend my hearty thanks to the entire team for accepting this our invitation, and thanks for all the participants. And over to the organizers for conclusion. Thank you.
Before
you.
Chetta sir takes up, I would like to tell thanks to Lakshmi Narasimhan sir for giving us this opportunity. So basically, I've seen many of the people being misdiagnosed as demyelination. So most of the time when we try to tell that it is not so, it becomes more difficult for us, I find, especially because they would have already been primed that they need to take immunomodulation and also. This was basically trying to see how we should be approached, and clinical neurology needs to stand for the test of time. So that was the reason for bringing about this
Thank
case.
you. Thank you.
Can I just bring about one flyer which we are trying to have?
Sure.
Yeah, if I can just share screen. Is this seen? Yes, I would like to invite all of you. So next month that we are having this neurological infectious disease course. This is basically 2 days course, which we conduct from last 4 years with Liverpool University at different parts of the world. So like last 3 years, it was held in Malawi, Brazil, and this time it is in India. It's going to be in Bangalore. It's on 16th and 17th February. So these 2 days, it's going to be a feast where it is going to be covered the complete spectrum of neurological infections. And this is mainly for all the postgraduates in not just neurology, in also in infectious diseases, microbiology, medicine, because neuroinfection tops one of the most important treatable disorders in India, but most commonly present. So this is going to be discussed. And there are a lot of posters and quiz which is going to be there. So what I would like request all the attendees, and sir, if you can please kindly forward it to your students.
Don't worry, we'll put it on the group and we'll
Yes.
ensure that everybody receives
Yes, I
this flyer.
request all
Thank
of them
you.
to
Thank you.
register and
Sure.
attend this.
Thank you.
Thanks everybody. Thank you.
Thank you.
Thank you, ma'am. Thank you. Please share this, the poster also, ma'am. So we will also forward it to all the DM and DNB
Sure.
students.
Sure.
Yeah.
Thanks.
So thank you. Today it's really a great day. We are completing 42nd session of Secret of Neurology, and I, Arun Chadha, Vice President of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 42 months. And I would like to thank our honorable course director, Dr. Sudhir Shah sir, Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on the neurology, which will be very helpful to all the DM and DNB students. And we are very thankful to young neurologist, Dr. Jayant, for the case presentation. And further to this, I would like to thank Dr. Vikram Hoda for symptom and evaluation and investigation of this case. And thanks to Professor Dr. Netravati ma'am, the Professor of Neurology, National Institute of Mental Health and Neurosciences, Bangalore, for sharing their experience in this case and providing the important learning points and proceeding of this unique case. Once again, we are very thankful to all of you for your gracious presence, and it's been a pleasure being with all of you today in the 42nd session of the Secret of Neurology. Thank you all for your presence, and we will meet again on the 26th Jan. This month again, on 26th Jan, yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all. Thank you. Thank you, ma'am. Thank you, Dr. Jayant, and thank you, Dr.
everyone.
Vikram.
Thank you.
Thank you, ma'am.
Thank you. Thank you. Thank you very much.
Support, you can end the session now. Ronak?
Sure, ma'am, I'll do that.
Thank you, Ronak.
Thank you. Thank you.
Thank
Thank you,
you,
Dr.
sir.
Harsh. Thank you, Shweta. Thank you.